Hi, I'm Dr. Arush Sabharwal. I am a lead surgeon from this center, and I'll be talking about and I'll be answering answering your few commonly asked questions on obesity. So here we go for a question answer session with our colleague Pallavi. Pallavi, yes, please.
Yes. So first of all, what is obesity?
Obesity is a metabolic disorder which is mainly due to overconsumption or underutilization of the caloric substrate. That means either you don't burn the calories that you eat, or you eat too much. Then WHO has already declared obesity as the largest global chronic health problem.
Okay. Then what causes obesity?
There are various causes of obesity, like one of the primary thing is excessive fat storage, which is due to your improper diet, your environment, lack of physical activity, genetics, endocrine, etc.
Okay. Then next, how does morbid obesity is different from being overweight?
Now, when we talk about overweight, being overweight is a reversible condition where it can be treated by medical management. Whereas morbid obesity requires a surgical intervention. Reason being, it is scientifically proven that if a person is morbidly obese, even if he tries to lose weight with diet and exercise, because of the yo-yo effect, you are bound immediately at the same time. At the moment you leave your diet, your weight will bounce back. Now, this is a very, very difficult situation where when you compare weight loss to diet and weight loss to surgical intervention. When you compare weight loss with diet, your actual muscle loss is reduced close to 30%. Whereas when you get surgically treated for obesity, your muscle loss is only 10 to 15%. And here we basically target only the fat loss and not the muscle loss at all. The body composition, the body mechanism, that controls a person's weight are set in such a manner that in morbidly obese patients, they gain weight easily. These patients rarely find it difficult to sustain the weight loss, and even more difficult to sustain the lost weight.
Okay. Then what are the complications of obesity?
Obesity has many complications. Like it can also deal up with depression, reflux, gallbladder disease, kidney stone disease, stroke, heart failure, atherosclerosis, diabetes, PCOS, male infertility like erectile dysfunction, hypertension, osteoarthritis, sleep apnea, varicose veins, gout, and so on and so forth.
Okay. Then how someone knows that he is obese?
Now, this is a very, very good question. That how would you really know that you're obese? Now, if we have to calculate the approximate ideal weight of the patient, it is very, very simple calculation. Your height in centimeters minus 100 for men That is, if you're 160 centimeters height and if you subtract 100, your weight should be approximately 60 kilos. And when it comes to a female, because they have broader pelvis, because they have to give birth, so 160 centimeters minus 105. So that means if a girl of 160 centimeters, her ideal weight should be approximately 55 kilos. Then there's a BMI category, there's a BMI criteria in which you are classified as being overweight, obesity. Then obesity has various classes: class 1, class 2, class 3, and then a super obese category. Then comes your waist circumference, then is your waist to hip ratio. Then you can calculate your body fat percentage. In a female it should be approximately 18 to 22, and in a male 21 to 25. And then there's an eyeball test. When it comes to an eyeball test, you can look at the patient, look at the person, and tell that he's a obese person. Yes, ma'am.
Okay. Then why should morbid obesity be treated?
Now, very nice question. Why exactly do we treat morbid obesity? Because morbid obesity is a disease like any other disease. It has become very important to recognize this disease as a cause of several and severe mental and physical problems, which show significant improvement after you lose your weight. Now, it is very important for the patient to understand that obesity as a disease with its complications and their inability to control them needs to be treated. After all, supposing if you have cancer, you will definitely get yourself treated for cancer. If you have diabetes, you will go in for a treatment of diabetes before they all flare up and become uncontrolled. So why not obesity, which is the root cause of all the major problems? Why not? Then, if you talk about the management of obesity, first and foremost, an obese person who when enters our clinic, we follow a strict protocol. First, we actually take a history of his attempted weight loss in the past, whether it's been supervised, unsupervised, medical treatment, surgical history. And if the patient has had a supervised weight loss for his obesity and his diet and exercise, then there are 3 ways to look at it. Number 1, that the weight loss was not satisfactory. Now, if the weight loss is not satisfactory, it is plain and simple that he requires surgical treatment. Then comes if the weight loss was satisfactory. And then, like I was telling you earlier, that because of the weight loss, as soon as the patient leaves diet, there's a yo-yo effect, like a seesaw. Once you diet and exercise, you go down. The moment you leave diet and exercise, you jump back, double up. Now, if there's overeating or wrong eating, then there'll be definitely weight gain. And there'll be weight gain to an extent which will be almost, if not double, at least equal to the amount of lost weight. At that particular time, you have to have a surgical treatment for obesity, because that is for sure the root cause of various other diseases. Then the third option is there's no weight loss. Now, if there's no weight loss, what to do? Then again you come back to the surgical treatment, and that's for it. After you do a surgery, you will lose approximately 75 to 80% of your excess body weight in 2 years. Now, what is your excess body weight? Supposing if you're a 160 centimeter female and you're supposed to weigh, your approximate ideal weight is 55 kilos and you weigh about 95 kilos. So that means your excess body weight is 95 minus 55, which is about 40 kilos. Now, you'll lose about 75 to 80% of your excess body weight in 2 years. Now, initial weight loss will be very fast. And we have seen in our practice, because we do follow a little pre-surgery diet depending on the obesity status of the patient. We do give the pre-surgery diet for at least a minimum of 4 days to a maximum of 2 weeks, depending on the BMI of the patient. Now, the various medical problems that are resolved with obesity surgery is migraine. Migraine are resolved to an extent of 57%. Depression, if it's because of obesity, then it will be resolved up to 55%. Obstructive sleep apnea will be resolved from 74 to 98%. Now, in fact, snoring is the first thing to go, because post-surgery, because we give a high, the anesthetists give a high peak, which is a positive end expiratory pressure, and it opens up the lungs so much that snoring goes immediately post-operatively. Then comes asthma. Asthma is about 82% resolved. Then dyslipidemia and hypercholesterolemia is about 67% resolved. Then when it comes to hypertension, it's nearly 52 to 92% of resolution of hypertension. If many people have non-alcoholic fatty liver disease, which means the fatty liver is not because of alcohol, because they don't drink alcohol, but they still have fatty liver. Now, non-alcoholic fatty liver disease has a resolution of 90% of steatosis, 37% of the inflammation is gone, 20% resolution of the fibrosis. Then metabolic syndrome. Metabolic syndrome is a combination of various diseases, which has gone up to 80%. Resolution of metabolic syndrome to the extent of 80%. Your reflux disease, your GERD, is resolved from nearly 72 to 98% of cases. Type 2 diabetes, depending on the surgical procedure, can be resolved up to 80 to 90% of patients. Polycystic ovarian syndrome, you will be very happy to know that for a disease which brings women infertility and facial hair. Now, a lot of people go in for IVF because of this thing. Now, PCOS, when it comes, it is divided into various categories. When it comes to hirsutism, which is facial hair, there's about approximate 80% of resolution of facial hair. 100% of people who undergo weight loss surgery, which is obesity surgery, have a resolution of 100% have a resolution for menstrual dysfunction. Their menstrual cycle will be back to normal and they'll be very happy to conceive. In fact, we have patients whose menses have been back to normal within 2 months, and although we counsel them to not get pregnant before 2 years, but this particular girl got pregnant after 2 months, and in fact in the first year of her surgery she delivered a very good healthy boy at our center here only. Then when it comes to stress incontinence is urinary stress incontinence. That means anytime that your abdominal pressure rises, whether it's because of cough or because of any other reason, whenever your intra-abdominal pressure rises, your you have dribbling of urine. Now, your dribbling of urine can be controlled from 44 to 88%. I mean, it's surprising what weight loss surgery can do. Then your degenerative joint disease, osteoarthritis and all these things can be resolved up to 78%. You may not need a knee replacement, a hip replacement and all these surgeries. If you just get with the weight loss surgery, venous status, that is something like varicose veins. You'll be surprised to know that approximately 95% of people get their varicose veins resolved. And gout, which is due to increased uric acid, there will be 72% resolution of gout. Now, quality of life improved is in approximately 95% of patients. And to an extent, I think weight loss surgery is the best surgery and the most cost-effective way for somebody to get resolution from all these multiple issues in their life.
Okay, sir. And then a very important question comes that what is a bariatric surgery?
Now, bariatric surgery is a very good and cost-effective treatment option for patients with morbid obesity, specifically people having various obesity-associated comorbidities. The surgery helps you to lose weight by lowering the stomach capacity and increasing the gastrointestinal motility. There are several surgical options today and each are having their own risks and benefits. We need to understand each and every procedure very, very carefully before you choose one or you undergo one. And today, a lot of centers are only doing one procedure, which is known as laparoscopic sleeve gastrectomy. So please be careful, understand all the procedures before you undergo any procedure from anywhere. Now, the various types of procedures that you can undergo is, first is a laparoscopic sleeve gastrectomy. Now, laparoscopic sleeve gastrectomy, by that we mean is that we create a sleeve out of the stomach. Now, the stomach capacity is practically 2.5 to 3 liters of an adult. And when it comes to a sleeve gastrectomy procedure, we create about 75 to 100 ml pouch of the stomach. Now, it is very important for you to understand that a sleeve is a banana-like sleeve, and sleeve is created from the GG junction about 1 centimeter away and excluding the entire fundus, the body, the antrum. I mean, that is what we do. We go about 2 to 3 centimeters from the pylorus. So we go right from 2 to 3 centimeters above and we go all the way to about 1 centimeter from the GE junction, and we remove the entire part of the stomach, which includes fundus, body and a part of antrum. Now, when we are doing a laparoscopic sleeve gastrectomy, we should be very, very careful of not going towards incisura angularis. It has to be at least 1 centimeter apart, or at least when you see the crow's foot there, you have to go away from the crow's foot, not on the crow's foot. Now, if you go close to the incisura angularis, there can be various symptoms like you can have a lot of reflux, a lot of vomiting, and to a certain extent leak. when we are talking about leak, we talk about leak which happens mostly at the GE junction, because we have to remember that the laparoscopic sleeve gastrectomy is a high pressure surgery. That means the fault is not actually at the GE junction. That means the surgeon has gone close to the incisura angularis. Now, when the surgeon has gone close to the incisura angularis, the gastric emptying from the sleeve above to the sleeve below will take a lot of time. And because of this, there is a high pressure which is created at the GE junction, which creates a leak. So, GE junction leaks are majorly due to the issues down below, close to the incisura. Then, for a mini gastric bypass is one of the most common procedure today. We found it, we've been doing in India, and it's very, very popular to people who want to live their life and lose weight. And now, sorry, because I left a point on laparoscopic sleeve gastrectomy. I'll come back to it. Now, laparoscopic sleeve gastrectomy being a restrictive only procedure, and you are basically restricting the amount of food that you eat. Now, we have to understand that a baby, when born, the mother feeds them about 5, 10, 15 ml of milk. If the baby is given 30 ml of milk at that particular time, then the baby will have regurgitation, reflux, the milk will come up, and slowly and steadily the baby's stomach will expand to an adult size of the stomach, which is from about 20-25 ml to about 3 liters. Now, the same way, after a sleeve gastrectomy, stomach has a tendency to expand. You cannot stop that. That's God's gift to you. But we can only understand that the lifestyle modifications needed after this particular surgery is insane. You have to exercise, you have to work out, you don't have to eat wrong things, you don't have to have liquid calories, you don't have to have sugary stuff, you don't have to have sodas, you don't have to smoke, because if you smoke you can even have some bit of reflux, which can even cause you Barrett's. So Barrett's esophagus is again a precancerous condition, which if people can smoke can lead into Barrett's. Then we come to a mini gastric bypass. Mini gastric bypass is a single anastomosis gastric bypass, which is basically we actually create a pouch of the create a stomach pouch right from the lesser sac, entering the lesser sac and dissecting it perpendicular to the incisura angularis, and then go above towards the GE junction. Once you have a long stomach pouch from the incisura till the GE junction, and you create just one anastomosis about 200 centimeters from the pylorus, and excluding the entire duodenum and the proximal jejunum, we are giving 200 centimeters of bypass. So it is also known as one anastomosis gastric bypass, or a omega loop gastric bypass, or a mini gastric bypass, and even some people call it as single anastomosis gastric bypass. Now comes, and the advantages is that because it has a long stomach pouch with just one anastomosis, that also with a longer BP limb which can give you malabsorption, the weight regain chances are nearly minimal. Then comes the Roux-en-Y gastric bypass. So when we talk about Roux-en-Y gastric bypass, I don't think it really needs any introduction, because it has been the gold standard procedure for about more than 50 years now. But recently the number of Roux-en-Y gastric bypasses all over the world, they've gone drastically down because of the invent of laparoscopic sleeve gastrectomy, mini gastric bypass, and then when you compare their complications to the complications of Roux-en-Y gastric bypass, where they have internal herniation and candy cane and all these issues, people have really stopped doing Roux-en-Y gastric bypass. But just to explain you, Roux-en-Y gastric bypass has a small stomach pouch which is about 25 to 30 ml of the stomach, and then there's a Roux limb which is lifted up, which is basically the elementary limb, and then the biliopancreatic limb, which is the BP limb, which is the limb which is majorly responsible for giving you the malabsorption in this particular thing. It is variable between 30 to 70 centimeters. Some people even do it to 100 centimeters and call it as long limb RYGB. And I particularly feel that why a person should undergo a Roux-en-Y gastric bypass. Obviously they have their own indications, but it can be used as a procedure for revisions rather than primary, because it's very easy to convert a sleeve gastrectomy or a LGB to the Roux-en-Y gastric bypasses. Now, the most interesting thing that today in the world that people are seeing is putting bands. I mean, you'll be shocked to know that they are selling bands like hotcakes. When it comes to people are doing banded sleeve gastrectomy, I don't understand the concept of a banded sleeve. Sleeve is anyways a restricted procedure. It's a high pressure surgery. You're anyways giving a high pressure to the patient for the reflux. It increases the reflux and all these things. Now you're putting a band on top of it. Once you put a band, the chances of reflux are there to stay, and you can never get rid of this reflux, because the moment your sleeve expands, then the band starts giving you the reflux. So I think putting bands in it doesn't make sense to me personally. It's something like the previous days when they used to do laparoscopic adjustable gastric banding, which is LAGB. Once they started, it became really very popular with the US and places like Australia, where people like George Fielding, and even my mentor, Dr. Laurent Liani, they've been doing crazy work with bands. But when it came to India, because it required a lot of follow-up because of the chances for band filling, you have to evacuate a band, and you really did not have any use of the band, because whenever people used to go out to party or a cruise or a vacation, they used to deflate the band. They used to come to the doctor, say, "Doctor, please deflate my band." And then once they were back, "Doctor, please inflate my band back." Now, once you inflate your band, you cannot inflate your band immediately full quantity. You have to slowly and gradually do it to see the patient's reaction to the band. Otherwise, patient will have so much of reflux that the band will slip. Now, band had its own complication: band slippage, band erosion, and in India, patients anyways don't come for follow-up. So how would they come for a band? So there was a saying that was practically followed by most of the surgeons in India, that band is banned in India. Now, the choice of procedure, I feel, should be made after a thorough discussion with your surgeons. You have to choose your surgeon, you have to choose your center sensibly, make sure that your surgeon explains you all the advantages and disadvantages of all the various kind of procedures when it comes to bariatric surgery, because we don't want you to have a revision. Bariatric surgery is more of a lifestyle modification surgery rather than, I believe, it's a weight loss surgery. I always tell my patients it's a lifestyle modification. You have to modify your lifestyle. If you don't modify your lifestyle, you will, and definitely you will have issues with it. Issues can be as simple as reflux to as simple as not losing weight at all, or weight regain for that matter. Issues can be anything. And when you compare weight regain chances of all the various procedures, mini gastric bypass has the least weight regain. But when it comes to the intake of various kind of supplements following a weight loss surgery is maximum with a mini gastric bypass, because you do a 200 centimeter bypass in length, and your proteins, your vitamins, your various vitamins are not absorbed in the duodenum. Your even iron, which is actually absorbed in the duodenum, does not get absorbed in the duodenum because your duodenum is bypassed. Then if you are planning to conceive, you need to go to a gynae who has been used to handling all these post surgery pregnancies, because it is very important to have a healthy baby after the surgery, rather than not having a healthy baby and then having an abortion. It can be really stressful. So please choose your gynae also very, very intelligently, and follow up with the dietitian, follow up with us, follow up with gynae. Follow up is extremely important after this kind of surgery. Now, yes, next.
Yeah. So what are the factors which affect type of morbid surgery?
Now, various types of factors that decide on the obesity surgery is, one is the BMI criteria. Now, BMI criteria for a person who might be a bodybuilder, he might be weighing 150 kilos and his ideal weight should be about 70 kilos, but his fat percentage is less than 1. In that particular phase, your BMI criteria fails. So better than BMI criteria is a waist to hip ratio. Then waist to hip ratio is one, BMI criteria is the other. Age of the patient. The oldest patient that we have done at our center here is about 86-year-old man, has been diabetes for about 35 years, and now non-diabetic. So various comorbid conditions that have been associated with obesity are very important to understand, because obesity and diabetes, obesity and hypertension, obesity and dyslipidemia, and all these factors are very important and closely related as a factor for obesity surgery. In fact, according to the new guidelines, we are doing obesity surgery even at a BMI of 27.5 with uncontrolled diabetes. Now, earlier category like the West was Western category earlier was 35 BMI without 35 BMI with diabetes and 40 BMI without any comorbid. Even the criteria there is lowered. Now, keeping into account for an Indo-American, when it comes to an Indo-American, is that if you are from India and Asian and you are settled in the US, will they be following American guidelines or Indian guidelines? Now, if they follow American guidelines, that should not be correct, because all the genetics and the background are Indian. So they usually will follow Asian guidelines rather than, and not American guidelines. Then patients' eating habits. Some are bulk eaters, some are small eaters but still not losing weight. Then the cost. Because if you take into account the cost of one surgery to the cumulative cost of all the medications that you will be having all throughout your life, I think the cost of surgery is way, way less. So, just to evaluate between the pros and cons, the cost of the surgery today is being so importantly placed in, not in us, but for the patient. Then is the patient preference for the type of surgery that they want. Now, whether they want a sleeve gastrectomy or a Roux-en-Y or a mini gastric bypass, we are here to do everything. But we suggest that if a patient is a vegetarian patient, should undergo a laparoscopic sleeve gastrectomy, because the protein intake for the patient would not not really be that much that it is required after any kind of a gastric bypass procedure. Then obviously surgeon preference, like I would do all three, so I can suggest you one. But there are a lot of people who just do laparoscopic sleeve gastrectomy, and if you go to a place like that, they'll just offer you a laparoscopic sleeve gastrectomy and they'll say that's the best. But people also say that laparoscopic sleeve gastrectomy is not a reversible procedure. When it comes to that, I would rather say laparoscopic sleeve gastrectomy is a self-reversing procedure, because the pouch will dilate and become into an adult stomach in due course of time. So all these factors, all these things are, and the type of surgeon you go to, whether it's like a high volume center like ours, or it's just a center where they only do laparoscopic sleeve gastrectomy, has to be evaluated.
Okay. Then what are the advantages of laparoscopy morbid obesity?
Now, advantages of laparoscopic approach is almost similar to any other laparoscopic surgery advantage. It has less post-operative pain to a certain extent. We mobilize the patient 3 hours after the surgery. We believe in ERAS. ERAS is enhanced recovery after surgery. When you say enhanced recovery after surgery, that means that the patient and anesthetists have to play a very, very important role, because they cannot give an anesthesia which will not have speedy recovery. So anesthetists have the major key role intraoperatively for ERAS. Then shorter hospital stay, early return to work, and improved cosmesis are a few. Then when it comes to ERAS, we actually mobilize the patient 3 floors up, so that patient does not come back and tell us that, sir, I was unable to walk, which is a major problem with everybody today. We will make sure that they walk in our center, but when they come back and they say, sorry sir, we can't walk. Now for people like those, they can even go on post-operatively heparin for about 6 months. But normally we prefer to give post-op heparin for about 10 days to 2 weeks. And if the patient is a little bit having an issue with the walk, which we realize when the patient is here with us, So we even give them for 1 month. And if we realize that the patient is really immobile, then we have to give them for 6 months according to that. Yes.
Yeah. So, is morbid obesity surgery for you?
You will qualify for obesity surgery for morbid obesity if you have a BMI criteria, if you follow the BMI criteria, which is BMI 30 with any issues like type 2 diabetes, metabolic syndrome, and all these, or a BMI of 35 without any comorbid. Then repeated unsuccessful supervised weight loss is also one of the major criteria that you should undergo bariatric surgery. Then bariatric surgery for that extent is also considered when you are unable to follow your own day-to-day routine. Now, for example, a mother or a father, and they are a little big. Now, with due course of time, they will be even getting bigger and bigger, and it is difficult for them to pick up their own kid and start walking. Then that means when you cannot pick up your own kid and you can't walk for a while, then how will you intend playing with him? You will never be able to enjoy his childhood. So that is also one of the things. Then you have to really understand the surgical procedure for weight loss before you actually undergo one. Because if you do not understand, you increase the chances of failure. Yes.
Yeah. Now then, how does this surgery changes your life?
Lifestyle change depends on various kind of surgery a patient has. Some common lifestyle adjustments are eat small, slow and frequent meals. We always tell the patient to divide your meals and to eat slowly. Do not combine water with your meal. You can have water half an hour before or 1 hour after your meal. Now it is very important because if you have water with your meal, then you have chances of reflux. Now, specifically after a laparoscopic sleeve gastrectomy, and the reflux can also be after a surgery like a mini gastric bypass. But if you understand the procedure mini gastric bypass, it has a big one anastomosis. So chances of reflux is really minimal. Then follow-up is really necessary. You're actually married, or you're actually become as a family to your surgeon, because you need to follow up with that particular doctor that you undergo laparoscopic surgery. And not only doctor, but his entire team, his entire clinic, his entire center, because the dietitian plays the key role in that particular surgery. When I counsel my patients, I always tell them that we as surgeons are mechanics. Now, supposing if a car is broken down, now if you try to drive a broken down car, you will not be able to drive it. But if you go to a mechanic, your mechanic will fix a car, and then you will be able to drive the car very comfortably. And how much distance you'll be able to drive the car before the car crashes down back again is actually the type of training that you have undergone. So we are mechanics. We can kickstart your weight loss, we can kickstart your broken car, but you have to drive it. You are your own best guide, your own best person to judge what wrong, what right are you eating. And 6 small frequent meals in a day has to happen, and you have to follow up with your dietitian. Please. Then weight loss will start soon after surgery. In fact, once from the day of surgery till about 10 days, once you come back for a review, we will definitely be having you will be losing about 4 to 5 kilos, and higher the BMI, higher the weight loss is more. Then, but your weight loss will be gradual weight loss to about for about 2 years, and will be approximately 1 to 2 kilos in a week when you compare the entire weight loss over the span of 2 years, not suddenly. And because sometimes even like very commonly in our practice, our we see that the patient has not lost weight in the second or third month, I think, but inch is being lost. So not only the weight loss is important, but even the inch loss is important. When it comes to post-surgical measurement, you need to measure your weight and your inch, and don't be headstrong that don't get after the weight loss that you have to measure it every day, but once in a month you should definitely measure your weight and your inch loss. Then improvements occurs in obesity related medical conditions, with almost 60% of them on an average do not require any medication at all. Then there's enhanced quality of life, your stamina, your self-confidence, your body image, and even your sexual life with your partner. Please remember, obesity surgery is not a cosmetic surgery. In fact, plastic surgery may be required following the weight loss surgery after you undergo obesity surgery. And today, when it comes to this pandemic of COVID-19, obesity has been clearly listed as one of the risk factors for COVID-19, and most of the patients who die of COVID-19 are obese, young people. So please get yourself treated for obesity and avoid COVID-19. Follow up the diet which is required, and be rest assured that everything will be there for you. Thank you. And also one and last thing, in case if you would like, you could log on to our website. It is also there. It is arushsabharwal.com, ARUSHSABHARWAL.com, and you can even write to us anywhere you want. Thank you.